So thank you everyone for joining us for today's webinar. Lawson's my name and I'm Chair of CHF. I'd like to begin by acknowledging the traditional custodians of the lands that we're all joining this webinar from today. I'm in Adelaide on the lands of the Kaurna people, and I pay my respects to their elders past, present and future. CHF acknowledges the ongoing contribution Aboriginal and Torres Strait Islander peoples make to the health and well-being of our communities, and recognises the importance of self-determination and community-centred services for good health outcomes for all Australians, including Aboriginal and Torres Strait Islander people. It's great to be able to come together today to hear from three expert leaders in our health system about Australia's priorities for health in 2021 and where we can hope to see some progress. We thought it would be opportune to reflect on the horrendous year we had in 2020 and forecast what lays ahead of us in 2021, hoping, of course, is going to be a much more positive year. There are some positive things on the horizon, such as the vaccine rollout. We know from experiences already early this year that we have to continue to be ever vigilant. CHF thought to assist us all get our heads around the challenges we continue to face in health, not all negative, of course, and there are some exciting developments, to tap into health experts and then obtain their views and insights into key priorities and what we should be aware of and opportunities for consumers to engage on key matters. I'll take a minute now to briefly introduce our panellists, and then they will each speak for about 10 minutes before we open up for a question and answer session. I know some of you sent in questions before the webinar, and you're also welcome to put any further questions you have in the Q&A box throughout the discussion. Try to get to as many questions as we can during the session. Our first speaker today is Dr. Brendan Murphy, Secretary of the Department of Health. Prior to his appointment as Secretary in July 2020, Brendan was the Chief Medical Officer for the Australian Government, and before that he was CEO of Austin Health in Victoria. Among his many memberships and associations, Brendan is a Fellow of both the Australian Academy of Health and Medical Sciences and the Royal Australian College of Physicians. Our second speaker today will be Amanda Cattermole. Amanda is the CEO of the Australian Digital Health Agency, having commenced that role in September 2020. Before that, she was the Chief Operating Officer at Services Australia. Amanda has also held senior roles in the Commonwealth Departments of Treasury, Prime Minister and Cabinet and Families, Housing, Community Services and Indigenous Services Affairs, as well as in the Victorian and West Australian governments. She will be speaking today about trends and upcoming initiatives in digital health. Today's third and final speaker, Christine Morgan, CEO of the National Mental Health Commission and National Suicide Prevention Advisor to the Prime Minister, Scott Morrison. Christine is a passionate leader in mental health care reform, committed to listening and responding to the voice and needs of those with lived experience. Before joining the Commission, Christine was CEO of the Butterfly Foundation and Director of the National Eating Disorders Collaboration. Today, she will be discussing what is needed for mental health and suicide prevention reform across the national system and how policy and services should change to benefit consumers. And lastly, while we're also going to be joined by Professor Ruth Stewart today, Ruth has unfortunately had to pass on her apologies due to a last-minute schedule change. Professor Stewart was appointed National Rural Health Commissioner in July 2020. As we can all appreciate, COVID is requiring us all to be a bit more flexible with our plans. And CHF will work with Ruth and her team to ensure we can hear her insights at another time. Thank you to our speakers for being available today. And please remember to add your questions to the Q&A box as we go along. I'll now hand over to Brendan to talk about the government's priorities for health and opportunities for consumers to engage in 2021. Thank you, Brendan.
Thanks very much, and thank you for inviting me to talk to this group. It's very clear, both for the department and the government, that our health reform journey has to have the consumer in the centre of it, and I think that commitment is absolutely genuine, and we do want to make sure that our very ambitious reform journey is consumer focused, and certainly consumers have driven a lot of the reform initiatives that I'm going to talk about. So I will start with COVID because it's what everyone wants to hear about. At the moment we are in a really good place with COVID, in that we have essentially controlled community transmission. We are continuing to get small little outbreaks from hotel quarantine, which is of concern, and but I think the states and territories are managing that pretty well. The big kid on the block at the moment is vaccines, and we are starting to roll out the two vaccines. We have two good vaccines that are being rolled out, and one of the most important things that I think that consumers can do is help us in getting consumer confidence in these vaccines. One of the reasons our vaccine rollout has been slower than a number of other countries is that we haven't had that burning platform that they have had of terrible pandemic deaths and hospitalisations, and they've had to do emergency approvals of their vaccines, whereas we put our vaccines through the full normal TGA process. One of them has been approved already, the Pfizer vaccine. That's going to be rolled out before the end of this month, initially to quarantine and border workers, and then into aged care and some frontline healthcare workers. And then the other vaccine, the main one that most of us will get, is the AstraZeneca vaccine, which we're making in Australia at CSL for most of it, and it still hasn't completed its TGA registration, but that'll be going through first. I think it's worth just mentioning that our vaccine strategy at the moment is to protect people from clinical disease, and particularly severe disease. We still don't know what effect it'll have on the concept of herd immunity, transmission, and how long it'll be before we can start to do things like relax borders. But we do know that if we have, the great majority of the population vaccinated, we will end up being much less reactive to small outbreaks, and we'll be able to start living better with COVID, and hopefully then moving towards herd immunity. So it'll be a huge logistical challenge, this vaccine rollout. Aged care facilities will have in-reach workforce. Some clinics will be run by states and territories, but we'll also be setting up a lot of clinics in general practices, and we'll be vaccinating people by their risk profile. So starting with people, older Australians, and then progressively moving to the general population. But I'm certainly happy to talk about that. There's a lot of noise out there in the vaccine space. The media is very focused on it, but the clear message I want to give you is that we have two really good vaccines. Both work very well at protecting against severe disease and clinical disease, and our strategy is to get as many people vaccinated as soon as possible, and so that we're protected. Other big policy initiatives that are coming up, probably the other one that's occupying my mind most of all is aged care. As you know, the Aged Care Royal Commission will be reporting at the end of this month. The Aged Care Royal Commission has been very critical, I think, of many aspects of aged care. I think perhaps hasn't necessarily given credit to those good providers that are out there that do provide high quality care, but there's clearly issues with with quality of care in some providers. There are clearly some issues with financial viability of the sector, and there's an increasing preference in consumers to age in their home. And so we're now seeing an interesting trend where residential aged care has vacancies and there's a waiting list for home care places. And we have to rebalance the aged care system to make sure that we provide the right resources for people to be better supported in the home, because that's clearly what people's preference is. There is the sort of reforms that the Aged Care Royal Commission may recommend are likely to be very expensive, and government has gone from a $4 billion surplus pre-COVID to a $200 billion deficit post-COVID, after having funded JobSeeker and JobKeeper and all of the COVID response, all of which the community supports. But we've got to think about sustainability, and there will be clearly a need to look at how people contribute to the cost of their aged care. We don't, have fair and equitable means testing across home care and residential aged care. Clearly, there's also a lot of issues around provider governance and making sure that all providers have the same level of clinical governance. There's an interesting debate about how medicalised residential aged care should be. Many of us feel that it needs to have very good clinical supervision, but we don't want to over-medicalise it and make it into a clinical environment. It is essentially people's homes. So the other major reform agendas, the Mental Health Productivity Commission report. What I might do is not mention that, because Christine's going to talk and she will cover the elements of that. But clearly there is a big issue about connectedness between the Commonwealth-run mental health programs and the state and territory-run ones, and I'll leave that to Christine. And again, there is a long reform journey. In the Commonwealth level, primary care reform is a huge agenda, one of Minister Hunt's major priorities. And again, we had a plan that was going to go down that of voluntary enrolment in general practices. COVID came and we've sort of converted that initially into the telehealth initiatives, which have been really helpful, and Minister Hunt's committed to keeping them going. But we do need to now start thinking about how to make primary care more multidisciplinary, have new models of care. And again, we're looking to go back to that idea where we want to encourage and support voluntary association with a practice and provide extra support to those practices that provide better continuity of care, more multidisciplinary care, and have new funding models for general practice. Medicare is here to stay. It's not going to go anywhere, but to support by additional funding models to make primary care stronger and better. And that will involve an increasing use of additional workforce in primary care, such as more practice nurses and more allied health practitioners. In the primary care space and more generally, the rural workforce strategy is as highlighted again, because we've actually had a reduction in overseas trained doctors coming in with COVID. It's exacerbated some of the pre-existing issues in the viability of rural general practice, and we're again funding some new models of support in partnership with the states and territories where the private market falls over. And there's a whole range of things I can talk about that we're trying to do to get doctors and all other health professionals into the bush. Another thing that was put on COVID ice was the private health insurance reform, and particularly the out-of-pocket costs work, which I know the forum was really heavily engaged in, and we are revamping that work. We're progressing with our out-of-pockets cost individual fee transparency website so that we can get exposure of variability. We publish, as you know, some aggregated data that shows that there is huge interstate variation between private doctors. But there's a range of other things we're looking at in private health insurance, like using private health insurance in out-of-hospital care more effectively, such as for mental health care in the community, such as for home-based rehabilitation. And there is a challenge about the viability of some of the private sector with people not choosing to take out private health insurance. So we're looking at a range of options to encourage that. Now, that's not to say that, as a nation, we are committed to a dual public and private hospital system, and we're obviously continuing to strongly support the state public hospital system. Preventative health has been a big topic of interest for many consumers, and we are about to launch for public consultation a 10-year national preventative health strategy. That's in early consultation has had a lot of good feedback, such as needing to feature more things around mental health and the effects of climate on health. But it's a broad-ranging strategy that is going out for consultation sort of in coming weeks, and we'd be really interested in getting as many as possible of the consumer groups to respond well to that. We probably coming out to my 10 minutes, but I'll just mention a few other things that we're doing. We are doing a lot of work on what we call health technology assessment reform. So in Medicare and pharmaceutical reform, we now have a guarantee that all drugs listed by the Pharmaceutical Benefits Advisory Committee will be funded by government, but there's a lot of work still being done on Medicare reform, and we're trying to make sure that we can have much more slicker processes to get new technologies, new tests approved for Medicare. There is a national medical workforce strategy, which has been a baby of mine, which again is nearing final completion, and it really is looking at the fact that we train enough doctors in Australia from our universities to meet all of our current and projected needs, but they're in the wrong specialties and in the wrong space. We've got too many doctors in Melbourne and Sydney, and we've got an oversupply of some specialists such as orthopaedic surgeons in Sydney, and yet we've got an undersupply in other parts of the country. So we've got to revamp our training system so that we train the right specialists in the right areas where we need them, and we've got to work out the right incentives to get them to where they're required. So I think I've gone for 10 minutes, and obviously the benefit of these discussions is more in the questions and answers than the talking heads, and I'll be very happy to participate in those going forward. Thanks.
Thanks very much, Brendan. There's a great deal happening, that's for sure. And as you would not be surprised, there are a number of questions coming through on vaccines. So before I ask Amanda to speak, I might just flick to Leanne and get her to pose a couple of questions around vaccines. Thank you.
Thanks, Tony, and thanks for that really comprehensive overview. We've got some really informed questions coming through here. Just for our audience today, I would point you to the recording. We'll make sure you get access to that. We did do a webinar on COVID and the vaccine rollout with Professor Michael Kidd and Lisa Schofield, the head of the Commonwealth Vaccine Task Force, on Friday. Some of the questions are being asked were answered there, but I might put a couple to you, Brendan, because they're coming in live in response to you had to say. Excuse me for the four-part question, but I think these are the main issues coming through. What precautions are in place for adverse reactions for monitoring long-term effects of the vaccine? The second one, probably one you'd expect given the media this morning, and we've already had to comment ourselves on radio. What should we be concerned about the South African variant and the efficacy of the AstraZeneca vaccine? I think this is a really important one. Where do carers fit in the vaccine rollout? Carers Australia are one of our members, and they're quite concerned that carers, as you say, we want to keep people, ageing older Australians in their homes, but why are carers not included in phase 1 as a priority group? Then there's the question of can consumers choose the vaccine they get?
So, yeah, there's a lot of questions there.
Yeah, I think, yeah.
The precautions. So again, what we've seen so far, there's been a lot of experience internationally. The incidence of adverse events is low. Probably the biggest concern is people who've had previous anaphylaxis with the Pfizer vaccine. That does seem been a small number of instances of significant anaphylactic reactions. So certainly initially the Pfizer vaccine will make sure that it's being given with people who've got the training and the supports to give adrenaline and all that sort of stuff. It's rare, but it's and it's not. We haven't seen. We have not seen any really significant complications other than that. But local reactions are quite common. Again, more with the Pfizer vaccine than the AstraZeneca. People tend to get more of a sore arm, and sometimes they can get a little bit of what we call systemic symptoms, a bit of sort of headache and sort of feeling a bit unwell for a few days. But that's more the Pfizer than the AstraZeneca. So again, we're making sure that all of our vaccine sites have the right supports and equipments, and so that's why we're not rolling it out to pharmacies until very late in the piece, when we're dealing with the general population and when we feel that we've got very good experience with the vaccines. So in terms of the South African strain, we don't really know. We think that all of the vaccines will have reduced efficacy against the South African strain, and there's some suggestion that they do. The AstraZeneca vaccine had a very small study in mildly unwell people, which has been in the media today. We still think that all of the vaccines will probably protect against severe disease with the South African strain, but it's likely that all of them will need to think about adapting, because they all really work against the same part of the virus, which is the spike protein, and they're all targeted to that. So the UK strain has some variants, and they all seem to work quite well against that. And the South African strain is more varied in the spike protein, and all of them in different studies, which are all very small scale. So at the moment, I'm still very confident the AstraZeneca vaccine will provide good protection against clinically significant COVID disease in Australia, but we're clearly monitoring that. And I'm certainly going to have the AstraZeneca vaccine, and I'll probably have it on TV to make people. So carers. So clearly, phase 1A is focused on residential aged care and residential disability care and the staff who work there, because we've seen that around the world where you've got people in residential setting, that's the highest risk environment. People in home care, home disability care, home aged care, they are certainly covered as people where they have chronic diseases, but more importantly, they will be covered because of the age groups quite often. So we are then focusing on older age groups, and we're not planning to have an in-reach program to home care and to carers, but we are certainly planning to. They'll have access fairly early on, according to their age groups. But we can certainly have a further discussion. There's still some work being done in that space, but it's a much lower risk environment than residential care. So the other one was choice of vaccine. Probably not. The vaccine clinics are likely to have one or only one type of vaccine. The Pfizer vaccine is likely to be distributed. Pfizer vaccine is going to come out in fairly reasonably small numbers of doses a week over the course of the year, and will be targeted again mainly to border workers, some healthcare workers, and aged care and disability care. AstraZeneca vaccine is the one that's going to be in most sites, and that's the one that most of us will get. And the GP vaccination clinics will only have the AstraZeneca vaccine, and that's where, and same with the state mass vaccination clinics. Now, again, we're continuing to review the data, and if there's any need to change that profile, we'll do that over time. But at the moment, I think our message is that both vaccines are really good. Both are going to protect people, and we need to the most important thing is to get as many people vaccinated with whatever vaccines available at your local vaccination place as soon as possible.
Thanks very much for taking us through those answers, Brendan. Back to you, Tony.
Yeah, thank you, Brendan. That's very comprehensive. Now I'd like to call on Amanda to address us and talk about trends in digital health. Thanks, Amanda.
Thanks so much, Tony. Thank you, everybody. It is a delight to be here. I really appreciate the invitation and to kind of talk to you along with my colleagues around some of the key areas that the agency is going to be working on in 2021, along with you and many of the consumer organisations and members of the community that you support and work with. I'd like to acknowledge the traditional owners of the many lands that we're meeting on together today, and pay my respects to elders past and present, and to any Aboriginal colleagues who are joining us around the country. I really appreciate this opportunity. I think it's about 3.5 months in now, and what has been just a fantastic time to join the Australian Digital Health Agency, and to particularly the time, as we've all seen, when the events of 2020 and really coming now into 2021 have provided just such an extraordinary opportunity for consumers to really embrace and use and be part of conversations about how digital health can be a really significant part of the way in which we provide the greatest access and engagement with the health system for Australians now and into the future. And so for me, coming off that, and really the agency having been quite a critical player in some of that, and I'll talk a little bit about that in a minute, but also really thinking for 2021 about how we use that moment to the greatest extent possible to continue to build that trust that I think consumers are really starting to get now around digital health and its role in the healthcare system, and providing really great access and bringing equity to different parts of the community in health, and also to providing coordinated care in building in and being able to support the kind of new models of care and areas of the health system that, for example, some of the things that Brendan touched on. And I'll talk a little bit about a few of those in terms of where we would like to be part of that, building the solutions that are going to help make the difference, along with getting that really significant consumer input into the way we do it, so that as we build out digital health solutions as part of that broader story, we do so in a way that is going to really make it as usable, as broadly based, and as engaging for everybody in Australia as we possibly can. And so really for us, that's what 2021 is about. And I just want to talk through a few of those. Some of them CHF is a really significant part of, others some of your members are, and there are also a range of other consumer groups and organisations and right across the health and social services systems that we are drawing on to ensure that we really embed these changes, this moment in time that we've got that's really going to uptick digital health for the greater good, that we do it in a way that gets it right. And there's a few things that we're really driving in 2021, and then a couple of things where we're going to begin the conversation, which will take us sort of into the next part of the 20s that I really also wanted to touch on. So obviously, last year we saw, a really significant broad-scale introduction of telehealth as one of those key flagship digital health game changers in part of the COVID response, and now obviously that becoming on its way to becoming a permanent part of our health system. And that's been absolutely one of the really, significant changes, and it has meant, of course, that we just see greater opportunity for people right across Australia to be engaging in online health services. One of the ways in which we've supported that work, and we want to continue to do so, is really ensuring that we set the relevant standards and safeguards in as part of that continued growth and support for telehealth, particularly obviously around privacy and security. And the work we're going to do with CHF and the Australian Patients Association to really embed those consumer views and perspectives around the way in which we develop those safeguards is an absolutely critical component of that. The other key piece, that's the companion piece to that we led last year that really will come to fruition this year, is our work in e-prescribing. Obviously, like everything, we accelerated it rapidly last year. I think we started in May. We're due to finish the entire rollout come April this year, and we're more than three quarters of the way through now. And that's really providing everyone with the opportunity to have a convenient alternative to paper scripts, as well as really improving patient safety by reducing those possible transcription errors that we can see from time to time in the translation between, GPs and other practitioners and into pharmacies. Nearly everyone's got that choice right now. I've used my first paper script with a telehealth consult last week, and it's just remarkable to have that engagement with my GP. We'd barely finished, it came into the phone, and off I went to my local pharmacy. I think we're at about 3 million e-scripts and repeats already, and we've got about 10,000 GPs issuing them, about a third of GPs, with well over 90% of our PBS approved pharmacies being able to dispense them. So we're well on our way to a full rollout. At the moment, using those QR tokens, many of you will have had a go with one. But the critical extra piece that starts now that we're going to roll out in the next couple of months is the active script list. We're testing that now in our first pharmacy in Melbourne. And the idea of that is to enable that, particularly people who have lots of repeats, or, for example, chronic conditions where they're using a range of different medications, to be able to have somewhere where all of that is held together, so they're not dealing with lots of different QR tokens coming in all the time. And it will just remove the need altogether for those tokens to be used by people for whom it'll just be a whole lot easier. So we're looking at increasing that from now. Once that testing is worked through, we'll roll it out from April, and then we'll really drive that through also into consumer apps, so people will have that available to them at their fingertips through 2021. And really what we need to do is work together on this so that you and the community groups and as well as our own agency consumer advisory group can make sure that we support that continued rollout of electronic prescriptions, that we take into account the needs of different groups within the populations, that we make sure the kind of consumer views are really at the centre of the way we're going to drive the rollout and deliver this solution, making sure people are comfortable with the kind of safeguards we've got in place, that we provide the right sort of guidance material for providers, and we engage with different groups to really, really make this a significant and ongoing part of our health system. And the idea of that is obviously our clinical governance frameworks, as it should, puts consumers at the centre. And this kind of work that we do with you as we roll out something as significant as e-prescribing gives life to that framework, really makes it real, that we are absolutely putting consumers at the centre as we drive these changes. The other thing I just wanted to touch on is the My Health record. I don't think I could really be talking about a forum from the ADHA without that. And one of the things that we really want to do is to continue to improve the functionality of the record while we also build out the future of the national digital health infrastructure. So just to touch on the latter bit first, it's not probably as relevant here, but just so you sort of got all the elements, we have commenced what we call our National Infrastructure Modernisation Program, with the introduction into the market of an RFT for an API gateway. That's being currently looked at by a panel right now. We will let that tender very shortly, and that gateway is one of our most significant pieces of infrastructure build for 2021. The idea of the gateway is it will enable messaging and information to be passed far more seamlessly across the health ecosystem. At the moment, as many of you know, of course, GPs and other practitioners are continually engaging in different technologies and systems and platforms. There's just so much noise in the ability to kind of navigate through, and particularly ensuring that messages between practitioners and consumers can pass much more fully and seamlessly through those different repositories and areas where all of that information is stored. The API gateway provides that. It will actually be the thing that will enable a lot of that transmission set to a bunch of standards to be able to move through far more seamlessly to get that information where it needs to be for consumers. So that's the big infrastructure piece, and that is the first of a planned series of pieces to improve the infrastructure for the future. But alongside that, we've got to do what everybody rightly says, and that is continue to improve the functionality of the My Health record itself. I've heard, since the day I started in this role, and no doubt, many of you will have heard from, through the people that you support, that it continues to be a frustration for people. It's often difficult to find the information. Sometimes it's not there and it's still pretty clunky. And so what we want to do is continue to drive that use and uptake. That's part of an ongoing program of work where we try and really drive, while we build out the infrastructure, we also try and drive change in areas where it's going to really matter. One of them is around work with specialists in private practice, where we're really working to ensure that we're working with software vendors to design software that will enable those practitioners to be able to upload their information far more fully, registering them for the My Health record, and then providing them with support to be able to do that. Got a lot of work on diagnostic imaging, pathology, and so on, to ensure again that those summaries and the imaging itself is more and more available. And as well as that, just touching on some of the other key reform areas, particularly a couple that Brendan's spoken about, we also want to make sure that we're doing some of this in areas where it's really going to make a difference. And one of the ones that I think that really requires that change is in the aged care space. One of the recommendations from the Royal Commission is to ensure that there's a real strong uptake of digital technology in the aged care sector, and in particular focusing on the My Health record. I think they've given us a year and a bit. And I think absolutely that we need to be driving that work as a priority to ensure that aged care providers can use the My Health record, and particularly in transitions of care, where we know currently that it's really clunky, information isn't always available, and really information often that people have put in themselves, such as their advanced care directives, where they're signalling decision making about how they want to be treated in the healthcare system, and that is often hard to find, particularly, for example, if people are moving from resi and into an emergency department. At the point at which it might matter most, we need to make sure that that's really available to clinicians in the most seamless way possible. So we've stood up our aged care advisory group. We've got a significant number of clinical, consumer and industry peaks on that group, and they're going to help drive that advice that we need to guide the direction of that project, so that we can really lift adoption and use of My Health record in aged care facilities, improve its functionality, enable it to connect with the clinical and administrative systems that are functioning often in resi, and then ensure that the information that people need at that moment of care, and particularly moments of transition, is available to them. Not only medicines information, allergies and so on, but also, as I said, the information they put in themselves, such as advanced care directives. We're also going to embark on a targeted education campaign for clinicians, for residents and their carers and so on, to ensure that people are aware of it and that we can support them in engaging with that, with the system, and with the ability to have that information available. In doing that, we want to really focus, of course, on the members of the communities and in resi for whom that's going to matter most, including thinking about ensuring that our material is engaging with Aboriginal and Torres Strait Islander groups, that we look at the rural and remote settings, that we really take into account the particular needs of people in those settings, and so on, as well as in other called communities, and really driving it right across the different parts of the community. And that will really enable it, as well as continuing to uptake that functionality, so that when you go in there, the material that you see is more easily able to be got hold of, and that starts to look and feel less clunky and much more like the kind of engaged health summaries and health information that you'd be expecting in 2021 and beyond. Part of that is the work we're doing on the vaccine, to ensure that we've got an application that will enable providers who are uploading their details in the Australian Immunisation Register to ensure that it's there, particularly those who don't have conformant software systems. That'll enable them to also engage and have that information from the Immunisation Register available to them, as well as also having a new document type in the My Health record itself that'll give us a consolidated immunisation view. So as we continue to be part of those reform agendas, we'll continue then to grow up and out the functionality, just make it more user-friendly, more engaging, have more of the information that Australians expect, and that we do that in consultation and engaging with different groups, while we also build the infrastructure for the future. And just touching again on some of that enabling work that is needed to make sure that we hit the mark when we do this, and we really support all the groups and parts of the community that need the support to ensure that that uplift, that trust and that engagement is there. We've also been doing a lot of work on digital health literacy. It's a key part of the agency's mandate. Last year, as many of you know, we put out our digital health workforce and education roadmap, which is really designed to ensure that we are providing frameworks for our critical healthcare workers who are, such an important part of this, the front line of all of this, to have the kind of digital literacy skills and to be able to go and get the support they need to engage fully with digital health as it really becomes such a significant part of the system. And we're partnering with a whole range of fantastic organisations to pilot different approaches to building that consumer digital health literacy more broadly, so that everyone can really fully embrace and use these emerging technologies. And so those partnerships are absolutely critical. We really look to continue to work with you to do that, because we need to make sure that all the changes that we're providing advice on and uptake for are really going to meet the needs of our community both now and into the future. Last but not least, I just wanted to touch on a little bit more about, so there's some of the things going on now. I just wanted to touch a little bit more about sort of what's next. Really, our National Digital Health Strategy, it currently sort of comes to fruition in 2022. We need to start the work now, of course, in engaging with everybody on the development of the next digital health strategy. And what we want to do is not only make sure we that it reflects all the significant changes that have come since the first one, but also that the way in which we go about that is really different. And we've had some fantastic advice from colleagues in some of the jurisdictions about the sorts of ways in which they have engaged on large changes to digital and other strategies in their jurisdictions. And we're going to try and really experiment with ways that will engage as many people across Australia as possible. So looking at a mix of digital channels, microsites that will enable us to have much more dynamic Q&As, the ability for surveys and forums and polls that are created in ways that will engage different parts of the communities, and make sure that everyone can have voices, as well as, of course, the more traditional means where we do some roadshow work and we make sure that we can be in lots of communities, listening to people for whom, they're not as confident, or it's not the way that they most best want to engage with us in providing their views. But we just want the benefit of that really contemporary way of engaging with Australians as we build out the next wave of our National Digital Health Strategy. And we're really lucky, of course, that one of the first big piece is in fact, of course, your big workshop in March. And that is a fantastic opportunity for you and your members to be absolute at the forefront of the advice we'll need about how we engage people and how we grow out the big things that are going to make the difference in digital health from here on. So I might stop there. That's probably enough for now. That's just to give you a bit of an overview of some of the key pieces that we're working on, and also a little bit of a signpost to that really significant work for the next wave of digital health from 2021 and beyond. Thanks, Tony.
Yeah, thanks very much, Amanda. Big agenda there. As I did with Brendan, I might ask Leanne to ask a couple of questions on your subject. Thank you.
Terrific. Thanks, Tony.
Yeah, thanks, Amanda. And thank you for also addressing digital health literacy and what the agency's work program is there. There were many questions on that. We do keep hearing, and it's here again in the chat, in the Q&A box, about the extent to which GPs are uploading or not health summaries and engaging with My Health Record. Obviously, their buy-in is a pretty critical enabler. Can you just elaborate or comment on a program of work on that front that's underway or planned?
Yeah, thanks, Leanne. We're continuing. I mean, GPs obviously are a significant group that we continue and engage with on an uptake of My Health Record. What we saw in 2020, and I can actually perhaps even provide a bit more detail with some statistics. I haven't got them at my fingertips, but they're some really interesting ones. But that might be of real interest to the people on this call. But what we did see, and I think is a greater uptake generally. So no question, we saw a greater uptake right across the system. But in particular, what we've noticed enormously, quite significantly, is the number of GPs and hospitals looking at material that has been put in by other parts of the health system. So what we're now seeing is not just GPs and others putting material in, uploading, but actually starting to use the information that's being provided by other parts of the system. And so that's one of the ways in which we are seeing that the use of My Health Record across the health system is improving. Part of the work that we'll do as part of the 10-year primary health strategy that Brendan was mentioning is to do more significant work around how we build that uptake, in particular through GPs, as well as focusing on other parts of the system in particular, like specialists, and also engaging in the kinds of records that we know people are most telling us they want uploaded. So, for example, one of the ones that we hear most is diagnostics, that pathology and radiology, and we're seeing very significant increases in the numbers of path and radiology material going into the My Health Record. And I think we've now got about 1 million diagnostic reports in there. I think my assessment in my time in this role so far is it is improving, but the improvement needs to accelerate further. And that's really part of our work program for 2021 and beyond, is to tackle uptake more generally, engagement and use more generally, but also to work with different parts of the system and different types of providers to drive their engagement and uptake in areas that we know consumers are telling us they most want to see, and clinicians are telling us would make the difference in the way in which they see and use My Health Record.
Thanks, Amanda. Back to you, Tony.
Thanks, Amanda. Okay, our last presenter for today is Christine Morgan, CEO of the Mental Health Commission, and over to you. Thank you, Christine.
Thank you, Tony, and thank you for this opportunity to be here. So thank you, Leanne, and welcome to everyone, including my colleagues, Brendan and Amanda. Great to hear about all of those wonderful things that are happening, and it's certainly a busy agenda. But I'd just like to pause firstly and to acknowledge the traditional custodians of the land upon which we're all meeting, but particularly for myself here in Canberra, the Ngunnawal people, and to pay my respects to their elders past, present and emerging. I would also like to pause and acknowledge and pay my respects to all of those who face the reality of living with mental illness, mental ill health, and those who care for them. I think as we've heard today from Brendan and Amanda, there is just so much on the health agenda, as there should be. The bit that I will speak to today is that bit that I think we actually were all reminded of coming off the back of what you had properly called, Tony, a pretty horrific year in 2020. And that is that we all have mental health. Mental health is as integral to us as our physical health. And what I think most Australians experienced last year was the impact in terms of increased psychological distress, anxiety, and how that actually goes across into the whole of your life. So those two words, mental health, cross a very, very broad spectrum, from our very severe, complex, enduring chronic mental illnesses, our schizophrenia and our bipolar, etc., right through to mental ill health and well-being. And it's a very broad range. 2021, off the back of a lot of work that was happening pre-2020, is the year for a significant mental health reform agenda. And at the Commission, we're working very closely with Brendan's team in the department and across the whole of government to say, what actually do we need to, should we be landing in 2021 through that mental health reform agenda at a time when not only do we have the significant commitment of our Commonwealth and jurisdictional health ministers and mental health ministers, but also the First Ministers and the Prime Minister, as was announced just prior to Christmas. A new minister assisting the Prime Minister in mental health and suicide prevention was appointed, cross-sworn across to our Federal Health Minister. Now is the time. Pre-2020, there was a lot of work happening calling for significant reform in mental health. Why? Why? Because the experience for people in the mental health system was very, very fragmented, was highly stigmatized. And I think what has effectively happened in mental health is that it's been birthed into and manifested through a health system, which very appropriately is quite a hierarchical system. It's very concerned about the impact on consumers. It certainly involves consumers, but an inherent distinctive factor of mental health, and this is a reform agenda piece, is that apart from those instances in which you can have a drug solution, and those pharmacological solutions are small rather than large, working with our mental health, working with our mental illness involves us. We need to actually be engaged. We need to find those ways of unlocking through our psychotherapeutic approaches how we can engage in our own recovery. It is absolutely critical that it's a multidimensional, multidisciplinary, and that it very much has us at the centre and works with us. That's a big reform agenda. We are, and I think before I get into the pieces that will inform that reform agenda and what we're doing this year, the interesting thing is that a lot of that work commenced pre-2020, identifying that we needed to do things differently. Then we go through 2020, and I think there are 3 or 4 things about 2020 that have formed a very useful lens through which we will now land the mental health reform agenda. The first is that reality that we all have mental health. And if we have mental health, then just as with physical health, we have to anticipate being unwell and at times being quite ill. Likewise with our mental health, we will be mentally ill. We will have mental ill health, and we do need to have a system that is affordable, accessible, and gives us continuity of care when that happens. So I think the stigma associated with mental illness and mental ill health somehow being a weakness was reduced in 2020. It is still very, very significant, mind you, and I think one of the most compellingly distressing components of stigma in 2021 around mental ill health is what I call the systemic or the structural discrimination. How when people reach out for help, engage with services around their mental health, or are required to disclose it, there can be a very negative impact. And I only need to stop and think of the reluctance of people involved in custody issues in the family law court to admit to any form of mental ill health for fear that it will have a negative impact on their custody arrangements. And that is but one of myriad examples. So we learned through 2020 that our mental health, is our core component. We also saw emerging in 2020 the importance of social connection. It was very important to us that, and I go back to the beginning of 2020. At the beginning of 2020, we had gone through that black summer of bushfires. And the single most consistent message that came out of the bushfires was we needed each other, we needed to be connected to each other in order to get through that horrific experience. It was only a matter of weeks later that we were talking about distancing and actually having to stay separate from each other. That had a significant impact on our mental health, on our anxiety levels, on our distress levels. And so we very quickly, with our colleagues in the mental health space, moved into a space which talked about, let's not talk social distancing, let's talk physical distancing with social connection. Now, this isn't just a warm and fuzzy thing. One of the concerns we've had through 2020 has been an increased expression of suicide ideation, an increased risk of suicide, and certain people have been feeling and expressing that. We actually haven't seen increased numbers. Now, that doesn't mean we're taking our eye off the ball by any means. We are very concerned to ensure that we continue to monitor that risk. But there is a newly emerging area of research interest now in what is the power of that social connection, because it was a very strong thing that kept us together and kept us propelled going through 2020. We absolutely were part of the digital health transformation with telehealth. And that is something that will be there, as both Brendan and Amanda have said, going forward. The challenge in particular for mental health within the telehealth is that, as I said up the front, that we need to be inherently engaged in our own mental health treatment, care and recovery. And to do that does need the correct blend between face-to-face and digital offerings. And that's a piece of work that Amanda and I have started to talk about going forward. What is that intersect between it, and what is particularly distinctive about mental health in that space? And the fourth thing that I think, the fourth thing that came through this, the fourth thing that came through was agility. We learned to do things differently, and that's got to inform our reform agenda. And the fifth that we're leveraging off this is that shift that we all benefit from towards a whole of government and whole of government's approach, where we actually saw National Cabinet came together. So going into 2021 and the reform agenda, we have some really significant pieces of work that are informing us. I think we have probably got a suffice of content now that we have to digest and make into an intelligible response. We have the Productivity Commission report into mental health. Now, that inquiry actually had more submissions to it than any other inquiry. It came up with exactly where we thought it would land, which is to say there's some really significant issues with the mental health service system, and it's resulting in a very expensive cost, both in terms of quality of care, in duration of life, and in our productivity and other economic costs. So there is a compelling need. You couple that with what is imminently to be released, which is the Royal Commission findings in Victoria. Now, yes, that's in a state jurisdiction, but sure as heck, it's going to apply across our nation. So that is really important. We had the opportunity that the Prime Minister provided for a deep dive into suicide prevention and how can we actually start to get those trajectory numbers down from in excess of 3,000 deaths per year, in excess of 65,000 attempts each year, down towards zero. So we've had some really good input from there. And we have now had National Cabinet and the National Federation Reform Council come together and say two commitments from a Commonwealth perspective. One, there will be a significant commitment in the May budget, and the Prime Minister himself announced this when releasing the Productivity Commission report and the suicide prevention advice. There will be a significant commitment in the May budget, and that will be a first step towards how are we changing the system. Then, most significantly, all First Ministers under the leadership of the Prime Minister have committed to saying that by November we will have a national mental health and suicide prevention agreement. This will be separate for the first time from the National Health Partnership Agreements. That is an incredibly significant reform. There is a tremendous amount of work that is needed to look at that. We're needing to look at what is needed at a multilateral level, what is needed in terms of those foundational architectural pieces that will actually turn our mental health system into something that is a good and positive experience for people. And there will need to be bilateral arrangements as to how we share it. Now, what are the key issues we need to address? The Commission had an opportunity through its Vision 2030 work, which was commissioned by our Federal Health Minister. He actually said, okay, let's not just look at how we can rearrange the deck chairs here. Let's actually look forward and say, what does a mental health system look and feel like? What's the experience if it's working properly? We have done a great deal of work in that area with many stakeholders. We're looking at it through the individual lens, and in particular, that is so much based around stigma, shame, discrimination. We're looking at the service delivery and the fact that in Australia, it is very much a case of postcode shopping because there is such a variation in consistency, quality, care, of delivery of services. And we're looking at the system and the barriers. And what we found when we were looking very deeply into this is that the single biggest issue of accessibility, once you put stigma and shame and all those things to one side, the single biggest accessible issue for people is affordability. Now, when we look at our universal healthcare system, and I've spoken to Brendan about this before, when you look at our universal health system, we really hold it up there internationally as being something which is universal, it's accessible, it's affordable, and you get good quality care. Now, yes, there are challenges, absolutely challenges with our geographic distribution and system is not perfect, but it is a very good system. 2021 is about laying the foundational pieces so that our universal health system has an alignment across for a universal mental health system, where affordability, accessibility is there for any Australian who needs it. To do that, one of the things that the Vision 2030 has called for, there's probably two fundamental things. One is that we move away from what we call our focus in on how much are we spending on mental illness to how much are we investing in people's mental health and well-being. Now, as soon as you move into that, how much are we investing in mental health and well-being, you're going firmly into the area that Brendan talked about of prevention and early intervention. And once you move into that space, you look at the fact that our mental health occurs across many parts of our life. So you actually need a whole of government approach to it. The second thing that has been called for is to clarify the system and work out who's doing what. In mental health, we have, if you like, three components. You've got your primary care, which is very much under the remit of the Commonwealth Government. You've got our tertiary care system, our hospitals, our outpatient, that's under the remit of the states and the territories. Then you've got fudge in the middle. I'm going to call it fudge, I'm going to call it grey. It's what we call our community-based care. And at the back of the Richmond report, we moved our mental health very consciously into community. It's just that we were missing in action when it came to saying, okay, what's the policy underpinning of that? What are the essential critical components of care that anybody should expect to receive in community-based settings? And who pays for what? Whose responsibility is it? And at the moment, it is partly funded by Commonwealth. You've got services funded by states and territories. You've got a very, very big NGO charity mix in there. You've got philanthropy, and you've got people who are doing what they are committed to. So actually clarifying that grey area and working out with our states, our territories, and the Commonwealth and other players, what are the essential components of care that people should expect when they're more ill than what could be dealt with in a GP setting, but they're not so ill that they need to be in a hospital setting? What should they expect? What are the essential components of care? How can we make sure that irrespective of where you live in Australia, you can get it? And most importantly, who's going to pay for it? And then embedded behind all of that is what are the outcomes? Now, in mental health, the single most significant difference we can make in a landing point is that we move away from just measuring activity in the system to what are the outcomes that we're achieving? What is the impact for somebody? That's an enormous shift. And all those other parts and components are needed. And then just to quickly conclude before we go to questions, in the suicide prevention space, as we did a deeper dive into that space, what we really found was that, gosh, the last 20, 30 years, Australia has done not badly in investing in what I call the clinical intervention space. But the clinical intervention space that we've tended to focus on is when I'm in suicidal crisis or at risk of suicidal crisis, or I have passed through that crisis and we have lost somebody, or we're dealing with somebody who has had an attempted suicide. Really pointy-ended. Now, we must not take our foot off the pedal. And in fact, one of the findings of the Productivity Commission report that I strongly endorse is that we continue to improve our aftercare. I'd love to see our aftercare moved, not just from when you have presented into hospital, but at an earlier point. But I actually think that we have misnamed it when we've called intervening at that point suicide prevention. I think that's suicide intervention. If we truly want to do suicide prevention that the Prime Minister's committed to, then the journey into suicide is a complex one that begins much, much earlier than that suicidal crisis. It is a culmination of many distresses in life. So the findings of the suicide prevention advice are effectively saying don't take our foot off the pedal with clinical interventions for suicide intervention, but match it with targeted distress interventions for suicidality. And as soon as you get into that, you start to look at where people live, learn, work, you look at their housing, you look at their economics, you look at a whole range of things. You need a whole of government approach. So that is actually incredibly aligned with the mental health reform agenda. Slight differences, we do need to keep the appropriate nuance, but it's significant reform. And then probably where I'll land and finish is that in both pieces of work, there has been an incredibly deep engagement with consumers and carers. Incredibly deep. With the suicide prevention one, we actually engaged with close to 2,000 people just in the short time we had to ask them what would make a difference. And in mental health, there's been a lot of engagement. What people keep calling for consistently is to say, work with us, not on us. Don't treat us as medicalised problems, but rather, yes, we know we need the health services, but we're a whole person. And most importantly, please make this compassionate. So there's a cultural shift piece that we need as well. So lots of different moving parts, but we do actually have the opportunity through these two significant commitments to a budgetary response and a national partnership agreement response to lay the groundwork for mental health system improvement in a really foundational way going past 2021. So a busy year, but an exciting one. And I'll stop there.
Okay, thanks, Christine. We will finish now around 1:15. We're going over time. Leanne will, as we've set the practice for this webinar, Leanne will ask you a couple of questions, Christine, and then we'll open up for some general questions and answers. Christine, can I just ask you to move a bit closer to your microphone because you were fading in and out a little bit. Thank you.
Thanks, Tony. Christine, we got some questions in advance of the webinar, and we've got several in the Q&A box here, but there's quite a bit of interest, probably not surprisingly, given our membership and constituency in mental health peer workers and the role of peer workers with lived experience as part of future mental health models of care and an area of workforce development. So can you briefly perhaps comment on that?
Certainly. So, and please, Tony, maybe you put your hand up if I'm not coming through strongly enough, and I'll try and increase that. So, peer workers are an incredibly important part of the workforce for mental health. I had an opportunity to speak to this issue just at the back end of last week. And to emphasise the importance of peer workers bring into the equation, working with clinicians, that actual experience. What is it that has worked or not worked, and what do we learn from that to ensure that our clinical interventions are actually working with people in a way that delivers a recovery focus that is appropriate for that person. So I think we get that. The challenges as we go forward is how we do this in an appropriately targeted way to cover the full range of mental health, from significant mental illness through to mild to moderate. How we do that, I think we need to move not from whether we actually try to push forward with peer workers or not. I think that's a given. It's an argument that is well and truly heard, and certainly we're committed to that. It's how do we do it as we cover this very broad spectrum of mental health.
Mute off. Thanks, Christine. Brendan, if I could come back to you. Obviously a setting of care that matters for people is general practice, and you talked about the primary healthcare reforms and that strategy and that 10-year plan being a priority for the government and the minister. We've obviously seen telehealth now paid for under Medicare, and comments from Minister Hunt that that's not going to be a temporary arrangement. Could you just briefly talk about what you anticipate the other major changes consumers can expect as a result of that plan? And I'm particularly interested because I think from the work we did with our Consumer Commission last year on their reflections on COVID and where both the policy opportunities lie and where the chasms in or the fault lines in our system were exposed perhaps more than they were normally in COVID, the relationship between social determinants of health and health. we're particularly interested in social prescribing and whether there is, you know, an appetite for that.
Yeah, so I think there's certainly an appetite and a push for it. I mean, the primary health reform agenda is going to take time, and I think that, again, one of the sort of first pillar of it is that we want to empower consumers more in that primary health agenda. And I think that the model of primary care, that we've got to move from a transaction-based medical fee-for-service model to a multidisciplinary care model where there are, you know, nurses and allied health and psychologists and the like in a, probably we'll start to see, you know, more bigger comprehensive primary care settings where, and we would also like to see interactions with primary care that are not necessarily based on a fee-for-service interaction with the doctor as the primary focus of it. So again, enrolment will be part of that, different funding models so that we can support a growth in the non-medical workforce and support more connected care, particularly after hours care, so that, you know, again, the PHNs have sort of got a role to play in that. So there has to be, you know, that we've had many attempts at care coordination in Australia over the years, and I think the primary care has to be the basis for doing that, and I think that's the sort of general direction, and I do believe that the GP community is generally aligned with that. They're very, you know, I think there's a nobody wants to do away with Medicare. Medicare has become sacrosanct in our mind. It is a consumer right, and I think it gives consumers power to choose. But I think it's a fee-for-service model has to be supplemented with other things. The other thing I think, you know, that the really other important focus is to try and deal with some of the equity of access issues. So we've got, you know, some primary cares set up in comfortable middle-class metropolitan suburbs that are really good, provide all of those sort of things I was talking about before. In other parts of the country, there are none. There are some practices that probably don't provide very good quality connected care. They're very transactional and very focused. And again, we're worried about telehealth, you know, potentially exacerbating some of that. So we're putting a lot of controls in place to make sure that happens. I think one of the other things that is coming out of all our consultations is that we need better data. We have very poor data coming out of primary care. It's limited. GPs are often a bit sort of protective of their data, but we put a lot of initiatives so that we can actually track what's happening, and we can say, well, in this practice, you know, the diabetes is being well managed and looked after in this practice. It is not in a punitive way, but to help practices come up to the same standards. So blended funding models, better equity of access, better data, and more a different workforce model are the sort of directions we're going in.
Thanks, Brendan. And all of those primary care reforms are not divorced from digital health reform and mental health reform, are they? The obvious connections are there. Look, we're out of time, so I might hand back to Tony for formal closure. We do have many questions, as we always do for these webinars, which is fantastic because they're a great indicator of the engagement of our members and consumers in the issues that you all have to talk about. We will collate those into themes for you and send those through to you all, because I think it just helps inform your thinking. You know, you can see firsthand without it being filtered by us what people are thinking and commenting and asking about. So we'll send those through to you. So thanks again, and back to you, Tony.
I'm sure all of us would be happy to answer some of those questions offline too, Leanne.
That
so
would be,
if you send them to the three speakers, we can get even people in our teams who know more than we do to help with some answers and send them back to you.
That would be lovely, and
Yeah.
we're more than happy to sort of serve as that conduit of those answers back out to our members and networks. Thanks,
Yeah.
Brendan.
Thanks, Brendan. That would be great if we could have that as a follow-up. That's been a really excellent session today. There's some really rich material there, some terrific and really challenging programs and services that are before us. This was a very popular webinar. At the peak, we had over 250 participants today, so that's indicative of the caliber of the speakers that we had, and the information that you were able to provide us was very greatly appreciated. So, I'll end it there. Thank you to Brendan, to Amanda, and to Christine for making your time available and providing us with some terrific material that we can digest and work on as we go forward. Thank you. Bye now.
Thanks, Tony. Thanks all.
Thanks, Leanne.
Thank you.